Good afternoon, everybody. Welcome to another edition of the AFR EMS case studies. My name is Chris Ortiz. I'm the EMS division chief for Albuquerque Fire Rescue, and today I am joined by our medical director, Dr. Kimberly Pruitt.
Hi, thanks for having me here, Chief. I'm in lieu of Manuel Martinez and his crew at Rescue 8. They couldn't make it today to be with us. So
awesome. We had a fantastic crew that submitted a great case that we wanted to talk to. They couldn't be here in person, so we're going to switch roles a little bit today and talk through as if we were the providers that were there. So thank you again, Doc, for doing this.
Oh, thank you. So, Chief, with your paramedic hat on, you're dispatched to as Rescue 8 with Engine 8 to a 26 Delta for a 66-year-old male who's reportedly just not feeling well. What kind of things are you thinking about as you're on your way to that call?
That's great. And I think what I would be thinking through is what's the causes for why this individual is sick. Obviously, the information that the dispatcher gets is only as good as what the caller provides. So a lot of times some of our sickest patients end up being just coded in the 26 Delta column. So I'm kind of on a high index of suspicion of what could be leading to their call today.
Super. And he's a little bit elderly too, so there's a good chance that there's probably something legitimately going on. Good. So tell me, you arrive at the house. Tell me what it's like when you get there. What do you see? What do you find?
Yeah, so it sounds like the crew arrived. We had a single-family dwelling residential structure. The scene was safe. We found that elderly man sitting in the bed, and he said that he felt very weak, and he said that his heart rate was in the 30s. The reason the family, who were great historians, knew that is they were utilizing a pulse ox that they had at home. The number didn't look quite right. They knew that was abnormal, coupled with the fact that he'd been tired for the last couple days. They made the call to 911 to check him out.
Okay. And so they're telling you that he's bradycardic. I don't know about you, but bradycardia is one of those chief complaints and things that makes me a little nervous on the inside because it's not always easy to fix. What did you see on your initial assessment when you saw him laying there in the bed?
So the initial assessment is he's awake. He's talking to us. GCS, if we had to give him a number, was 15, so conversing just like you and I. Had a good airway, normal breathing pattern, had good palpable radial pulses. Did say he did have some nausea and felt like he was going to throw up. Did feel a little bit dizzy as he was sitting in bed.
Okay, and probably being bradycardic, those other symptoms kind of make sense, right?
Absolutely.
And so with a bradycardia complaint, you want to get him on the monitor right away, get a 12 lead right away and see what you're dealing with.
For sure.
What did you think, what else did you find during your secondary assessment, vitals and physical?
Sure. So after you have the crew start getting those baseline vitals, we did confirm that it was a rate of about 37 is what was showing up on the monitor. And we was matching what we were feeling at that radial pulse. Blood pressure was still okay, 110/48. He was satting 96%, breathing about 20 times a minute, and then we were getting good capno. So you talked about the getting him on the monitor, so obviously we want to get him on a 12 lead as quickly as possible. We got the leads set up and take our initial look with that 4 lead, and right off the bat, we're picking up a very slow rate that matches kind of what we're seeing on the monitor here of about roughly 40 beats per minute.
Okay, and I'm glad to hear that you took a pulse. I always think it's important to touch your patient. One, you can feel the character of the pulse. Is it thready? Is it weak? Is it even there? And then you also get to feel their skin. Is it clammy? Is it cold? Is it hot to the touch? There's a lot you can gather by touching your patient, so I'm glad to hear that happened, and you confirmed he truly is bradycardic. Now we kind of have an explanation of his symptoms. The 12 lead that they got looks to me like I do see P waves before every QRS. They're easiest to see in lead 2. PR interval looks okay. We start the same way every time, so rate truly bradycardic at 38. Rhythm, P waves before every QRS. Axis looks good. We look at 1 and lead AVF. The QRS vectors are mostly up in those 2 leads, so that gives us a good axis. Intervals on this, interestingly, the QRS is normal. It's nice and narrow, which is good, but the QT is really long at 536. Remember that if it's over 500, we're at risk for spontaneous arrhythmias. And with this guy being nauseated, this is probably someone I would think twice about giving Zofran to, just because the QT's long. But I don't see any other ischemic changes on there. The ST segments look good, no flip T waves. So good 12 lead. Looks like sinus Brady.
Absolutely. So we got, as we're doing that, we're getting some patient history. We found out that he was diabetic, did have a history of CVA, had some kidney disease, but was not on dialysis, had a history of high blood pressure and high cholesterol. So a lot of the very common issues that we see amongst our patient populations.
Okay. And did you notice anything else pertinent on physical exam? Or
So aside from the fact that he was alert and awake, he was slightly pale. We talked about the fact we know he is bradycardic. That was confirmed. Lung sounds were clear. Abdomen was soft. No signs of trauma. So we had to start making the decision. Obviously, this is something cardiac in nature is the path we were going down. But the fact that he was awake, alert, right now was hemodynamically stable. We were going to treat this individual as being bradycardic, but that he wasn't unstable at this point. So we wanted to go down the different care paths to be able to treat him as a stable bradycardic patient.
okay, but stable symptomatic bradycardia. Okay, and what did you decide to do? You wanted to treat him there on scene to help him get to feeling better, right? This
Absolutely.
is a rate you want to correct before he gets unstable. What were your first interventions?
So aside from getting the regular EKG, getting our 12 lead set up, we wanted to ensure that those pads were on, because although he's stable talking to us right now, there was definitely an opportunity for him to take a turn for the worse. So we wanted to be prepared and not be working from behind the 8-ball. So obviously we got the EKG on, we got the pads placed. We wanted to start an IV to try a little bit of a fluid challenge. And then once that IV was successfully established, we started thinking about atropine.
Super. And then what was your dose for atropine?
Our atropine, we gave him 0.5 milligrams. We realized we can give a total of up to 3, but we wanted to start it with the 0.5 to go slow.
Super. And how did that work for you?
It worked well, actually. Our repeat vitals, secondary to giving that medication, we saw an increase in his heart rate up to 60. His blood pressure came up a little bit, 118/74. He was now saturating at 100% on the couple of liters of oxygen that we provided, and his respiratory rate was 18. GCS scores were still staying the same. He was able to talk with us a little bit more, and that's when we started to shift to be able to begin our transport, because we knew, although we had fixed this in the short term, there was definitive care that he definitely needed.
Yeah, figure out why this happened. Excellent. So I'm really glad that atropine worked. Sometimes it doesn't. In fact, what would be your plan if the atropine hadn't been effective there after a couple of doses, as you mentioned?
Oh, that's a great question. I think if we found that the atropine was not effective, and we slipped into what he became either unresponsive or less responsive, and or had a dip in his blood pressure, then we know that at that point he's symptomatic, he's bradycardic, but now he's unstable. So if our atropine wasn't working well enough, then we know we need to revert to electricity, and I would have chose to pace.
Okay. And then do you mind walking me through some of the steps of how to pace, and show me here on the monitor what to do?
Not at all. One of the key points that we want to stress is that we had the leads in place, the limb leads, and that is key. We won't be able to pace even with the pads on if those leads are not in place. So those were already in place. We had his pads on because we were already prepared for the worst. Our monitor was already on, so we're going to go over to our pacer. We're going to hit that button, make sure that it illuminates. It's automatically going to set for 70 pulses per minute. We're going to go ahead and set that as a starting point for us.
Okay, you're telling the computer to make sure that heart's going to beat 70 times a minute.
Exactly.
All right.
Now, the next step we're going to look for is trying to gain electrical capture.
Okay.
So we're going to get our milliamps set. Typically, we start wherever you're comfortable with, but we're basically looking for that pacer spike to line up with the QR
That's
compass.
this arrow here, right?
Exactly.
Okay.
So we're going to continue. As we're doing that, I'm also, like we talked about, getting hands-on with the patient. We're going to feel for a radial pulse, because along with the electrical capture, we want to ensure that we're gaining mechanical capture as well.
Okay.
So I'm right now at 70 milliamps. It looks like I've achieved an appropriate electrical capture. I do feel a radial pulse at this point, so I know I have mechanical capture as well. I'm going to go ahead and bump up about another 10 milliamps just to ensure I maintain that, and then I'll go ahead and click the speed dial button again, and that pacing is going to be set.
That locks it in.
Exactly.
Super. Okay. And let's say at this point he starts to feel better, because now he's perfusing more, and you see his chest kind of flexing with the electricity, and it starts to hurt. Do you have kind of a thought process as how you would approach maybe medicating him?
Absolutely. I think since it's obviously not a comfortable intervention, we want to make sure that we're keeping them calm and as comfortable as possible. So one of the medications we want to go to is fentanyl, and we talked about the choices between fentanyl and Versed, and me and you had the conversation that your preference would be fentanyl. If you want to talk through that for me.
Yeah, I'm happy to talk through that. So we have both options in the guideline. When I think about Versed, there's a couple of things that make me a little bit wary about using it. One is that can decrease the blood pressure, and we're talking about pacing an already unstable patient, and so I don't want to really take a chance of making that blood pressure worse. And we're also basing the pacing decision on mental status. So Versed is going to change your mental status and potentially change your blood pressure, and then you're stuck with, well, is this the medication that's doing this, or the actual cardiac event? And so it may cloud the picture a little bit, whereas fentanyl will treat the pain, but maybe not change their mental status as much or their blood pressure as much. So I would err on the side of fentanyl. And the truth is, even if it wears off a little bit, you can give more, but a little pain in this instance won't necessarily be a bad thing. It may increase that sympathetic drive and actually increase the heart rate, intrinsic heart rate, a little bit as well. So my choice would be fentanyl, but Versed's not a terrible option either. That's why we have both in there. And then if your patient remains unstable, even after you have electrical and mechanical capture, if they still are hypotensive, epi is a good choice here, because epi also has a increased, it'll increase that sympathetic drive and also inherently increase the heart rate, hopefully.
That's great. And that's exactly the course that we were thinking of. Obviously, you want to start thinking ahead during transport as to what led to this. So one of the acronyms that sticks in my mind is the DIE acronym, DIE. And we think through drugs, is this ischemia or was this electrolytes? So in terms of drugs, is the patient on beta blockers? Did they have too many of their beta blockers, and what's leading to that? The ischemia, are we talking about high level blocks? That's something that nothing that we can fix in the field, but good to know when they receive their definitive care. And then, of course, electrolytes, specifically looking at potassium and things we want to think through during transport so we can relay that information to the docs.
So glad you brought up potassium. This is a very common thing that comes up, and it's important to talk about because it's easy to miss. Bradycardic patients, like I mentioned before, they're difficult. They have potential to be really, really sick. And I like that acronym DIE because they're really pretty close to dying usually. And so we need to figure out why, and we need to figure out how to fix it fast. One of the important points is that if they're hyperkalemic for any reason, underlying renal failure, worsening renal failure, not even have to be on dialysis. Maybe they've been laying on the floor for 3 days and are in rhabdo. In-stage hyper-K, very severe hyper-K, can present with a very wide, complex, very slow rhythm. And it may look for all the world like bradycardia, but the treatment algorithm for hyper-K is a completely different pathway than atropine, pacing, and epi. For hyper-K bradycardia, what you need to be giving is albuterol and probably calcium. And if you don't at least think about hyper-K when you have your bradycardic patient, you may miss it completely and go down the wrong track. And it's easy to do. I think we've all done it. And the upside to thinking about albuterol and thinking about calcium, they're really not going to cause harm. Albuterol, what does it do to the heart rate?
And increase it.
Increase it, so it may help, right? And then calcium as well. It's basically, I don't want to diminish its utility, but it's essentially just a vitamin. If you've done anything, you've made their bones stronger, right? So there's no downside if you think it may be hyper-K, why they're bradycardic, and typically you're going to see a wide QRS complex, which we didn't see in this case. Go ahead and try that albuterol and try that calcium and see if it helps, because it's a completely different pathway and it may make all the difference. Yeah, excellent job on this case.
Hats off to Station 8, Lieutenant Martinez and his crew, Rescue 8 and Engine 8, on their care for this patient, recognizing early the needs of the patient, recognizing stable versus unstable and how to treat it, and then thinking through the thought process that if the patient was to decline, they knew exactly what they were going to do. So fantastic job to them.
Yeah.
And thank you, Doc, for helping us cover that.
Thank you.
All right. Well, that's it for today's case. I appreciate everybody tuning in. If you have cases to submit, please use the SharePoint tab. And if there's any questions, reach out to your assigned 7-8. Until then, we'll see you next time.